Putting a course like this together is a lot of work, and during the process, the four of us had a number of meetings. And during those meetings, we had a number of discussions that we thought would be interesting for you as a learner to observe. With that in mind, we thought this might be a good opportunity to join us for a more casual discussion about the creation and content within this course. Hello, I'm Dr. Shawn Thistle. I'm here with my friends and colleagues, Dr. Dimitri Simakopoulos, Dr. Peter Stillwell, and Dr. Kent Stuber. We're all chiropractors with different areas of expertise. We have a clinician who deals primarily with chronic pain patients. We have two of the world's best researchers in the area of biopsychosocial care and patient-centered care, and then me, I'm in the knowledge transfer space. Gentlemen, why should chiropractors care about the biopsychosocial approach, and what challenges does it pose for practicing clinicians?
I think I'll jump in first, guys. My belief is that different patients need different things at different times. And when a person's in our office, we really should be able to identify what those needs are and whether or not it's something in addition to what we can provide. So really we need a lot of more skills than what we learned in school to identify those things and then get people the care that they need. So that's just my clinical impression from that standpoint.
Yeah, I think from a research standpoint, like you look at clinical practice guidelines and it's consistently recommending that we need to take a biopsychosocial approach, and I think that's often confusing for clinicians. They're like, what does that actually mean? They want an actionable framework. So that's what excites me about it, is like, let's really get to the details about it. Like, what is a biopsychosocial framework? How do we actually apply that? And how do we actually improve patient outcomes through that process?
For sure, because most of the guidelines, they recommend it full stop, and then it stops there. They don't really say how to do it or what the components of it are. And so practicing clinicians are kind of left with their hands up in the air, like, what do we do about it, right?
Yep, I think it's actually a really great opportunity for us as chiropractors, because I think when you look at our professional DNA, there's a lot of elements of the biopsychosocial approach that are actually really like cohesively, intertwined with what we can do well as chiropractors. We just need to up our game a little bit and incorporate more elements of it.
Yeah, the point is, chiropractors traditionally have done a lot of the things within the biopsychosocial model well over time. And, emerging evidence, and now that we have researchers in our own profession doing the good work in this field, it's important that clinicians understand what's new and things that they can enhance in their clinical practice. So what do you think some of those things are?
Rather than searching out what exactly I'm going to manipulate or do soft tissue on or something like that, and really steering your treatment in that direction, it's really just about how can I enable you to do things that are meaningful to you, and how can I facilitate that? So it's really just about developing that therapeutic alliance and making it person-centered. So that's kind of what bridges what you guys do to what I do as a non-researcher. So I'm really informed by these two amazing gentlemen here.
Yeah.
And it's changed the way I practice.
Yeah. And is this sort of approach and these concepts just for chronic pain patients? Or can we apply this to an acute low back pain patient, for example? How does a biopsychosocial approach fit in with an average patient that we might see in a chiropractic office?
Well, one of the things I relate it to a lot is, and I talk about this with patients in my clinical practice, is it's astonishing to me as a chiropractor how often it happens that I'll see a patient come in with an acute, really hot low back pain right around the holidays, or right around the time they're going on a holiday, going on vacation, or there's something just massively stressful going on in their life. Yeah. So it's like there's an acute case that's super intertwined with the psychosocial elements of their lives as well. So I think it can apply to anyone.
Yeah, it's things we see all the time, right? And I think it's a matter of just sort of itemizing it in terms of how you think of what can influence a patient's clinical condition over and above, like you said, like what level do you need to adjust or what soft tissue do you need to touch. So I think it fits in quite well with most of the cases that we see, whether practicing chiropractors kind of realize it or not. And that's sort of what we've been working on the last little while, right?
Yeah, and I think historically, there's been this really strong emphasis on the biological aspects, so anatomy, biomechanics, and essentially the biopsychosocial framework is prompting us to take a bit of a bigger picture look, so incorporating those psychosocial elements that have been historically neglected.
Yeah, and you know, Peter, your research focuses on the traditional application of the biopsychosocial model and bringing us forward with it. So tell us about that.
Yeah, I guess I got excited about it clinically, and then through research, I was like, how are people actually like applying the biopsychosocial model? So as proposed by George Engel, and we quickly realized that a lot of people are talking about the biopsychosocial model, but they're not really sure how to apply it, or they think they're applying it, but really they're still emphasizing anatomy, biomechanics, and paying lip service to the psychosocial elements. So we've published some work kind of outlining some what we call kind of misapplications of the biopsychosocial model and some ways forward to kind of provide clinicians and researchers with a more contemporary framework to guide research and practice. So it involves, that contemporary kind of framework involves things like, Dimitri, you already mentioned, like listening, building that relationship. It includes features like that.
Yeah, that's really cool. How does patient-centered care fit into a biopsychosocial model?
Yeah, I mean, really, the biopsychosocial model is person-centered care. You know, you look at the patient as a person. You try to establish a good therapeutic alliance with that patient. You try to work with them together. So it's, you know, they're really, you know, they really seamlessly work together.
And when you see this in your practice, Dimitri, how do you know when a patient, I mean, you see mostly chronic pain patients, how do you determine which patient may have more psychosocial factors versus biomedical factors, and how do you arrive at that decision with your patients?
I really think that those two things are intertwined, right? I don't think that you can separate pain and psychosocial elements because they're one and the same. So I don't really think that psychosocial elements are a cause of pain. You have to be mindful of the fact that that person's pain is real, because the implication is that the psychosocial elements are, you know, triggering something in that person, and that's a somatization of their psychosocial stressors. Mm-hmm. So that person might have something, and likely has something physical going on that you need to be mindful of, but really it's just about what's stopping that person from moving forward in a meaningful way, and how can we break down those barriers, if that's a skill that you have or if it's within your scope, and then help that person get to where they want to be.
Yeah, I mean, Kent, you and I are about the same age, and when we were in school, we were kind of taught about chronic pain as a dichotomy, like it's either real or they're faking. And we were sort of trained to try and spot the fakers, right? And there were these, you know, yellow flag concepts that were either black or white. They were there or they weren't. But I think what we've seen in the literature from our researchers and also from our clinical experience is that you can't untangle all of that stuff. And you know, as Dimitri said, the psychosocial factors mix in with the biomedical factors with everybody. And I think it's just a matter of what's dominating the scenario. Would you agree with that?
Yeah, I think this brings up a variety of points. Like, I think we need to understand what we're talking about if we're talking about pain, because I think historically we've confused pain with injury, we've confused pain with nociception or those danger signals. So I think if we look to like kind of established definitions, like from the International Association for the Study of Pain, pain is a personal or subjective experience. So if we take that really seriously, we can't then just do some investigation into the body or do some sort of laboratory test and say, oh, this person's faking or not. Like, now it's quite well established that that's the wrong way to kind of think about it. So the best kind of tools that we have is to talk to the person, listen to the person, ask them if they're in pain, and we have to take that as the patient describes it.
No, there's no biomarker for it, I think is what you're getting at. And it's astonishing to me how much time and resources are put into identifying a biomarker for pain somewhere in the person's body that allows a researcher or a clinician to definitively conclude that it's real.
Right.
But at the same time, the definition is that it's a subjective experience. So they're trying to objectify that somehow, which is kind of confusing.
Yeah, it's kind of a false chase, isn't it?
Yeah.
It's not an on-off switch for most people.
Exactly.
And that presents a challenge. So, you know, as a group, we've discussed the use of outcome measures and different tools in clinical practice. And, you know, we all went through clinic year as chiropractic interns, remembering how much patients kind of dislike the paperwork, so to speak. And we have a number of forms in our profession to use, but what are some of the factors we should consider about when to use them? Not necessarily which ones, but how do we employ tools like that effectively to give us some information and not irritate the patient, I guess? Yeah.
I think one of the first things we need to consider, even before the when to use them, is why are we using them? I think there are so many forms that are out there. You could outcome measure your patient to death, and really like
a pile of papers.
Yeah, absolutely. It's like, here's your book. Try and figure that out before we see each other in half an hour. Right. So we need to figure out, okay, why are we actually using these outcome measures? Absolutely, outcome measures can be important, but we have to have a good reason to use them. And then it's if we're going to use them, we have to actually make use of them. Yeah. And I think that becomes a really big problem. Like, a lot of clinicians will have an outcome measure that they're like, okay, let's get you to do the neck disability index, but then they never actually take it up with the patient.
Right.
And so what good has it done anybody? Has it done anybody at that point?
And the patient wonders, like, why did I fill that out for you? And why am I filling it out 3-4 times in a 2-month period? And I just remember, I never used them a lot in my own practice, to be perfectly honest, but there's just a frustration level with answering the same questions over and over again, particularly, as you said, if the clinician doesn't circle back to it and say, I see you said this on this form, what do we do about that? Yeah.
I mean, building on that point, and Kent's point, of course, is we should use them when we need them, right?
Yeah.
There's, of course, a questionnaire is no replacement for a clinical interaction, right? I think we all agree there. So use of a questionnaire should be solving a problem that we can't solve in that interaction. So if I need to substantiate funding, then I might use an NDI, right? Or if I need to prove to an employer with a kind of quasi-objective data that someone has improved, I might use a questionnaire that allows them to have something in hand.
Or an insurance company.
Or an insurance company, or something like that. Or if diagnosing depression is outside of my scope of practice because it lies in the DSM realm, well, if I suspect that someone has depression and I want to raise that with the person's family physician and think that they might need some kind of care, I might say, well, look at this depression index. They endorse pretty severe symptoms. Maybe you want to have a conversation with your patient about this, or I can educate them. So it should steer my practice somehow.
And how do you, chiropractors are often not comfortable talking to patients about depression and anxiety. So, you do that every day. How do you bridge that gap? And what would you tell, chiropractors in terms of how they can improve their communication style or how they do this with patients?
It's a tough conversation at the best of times because it's not something that we're really familiar with. At any rate, I think that you have to approach it after you develop that therapeutic alliance, number one. And number two, you have to approach it from the standpoint of empathy, right? Like, you're having this discussion for a reason. And really the way I think about it is that no matter what the psychological or psychiatric condition is, it might affect that person's ability to engage in things that they want to engage in, that if they were to gradually return to them would be a good therapy for their pain. I have a patient right now that I'm working with who I really would love to start a walking program. But it's not pain that's stopping her from doing that. It's the fact that she can't get out of bed because she's so depressed. Her mood is so low that she can't get out of bed. And that's one of the inactivity is one of the contributors to her pain as well. So they're intimately intertwined. But the reason why this person can't get out of bed is because she's depressed. So we have to figure that out. It's another variable that might lower a ceiling for someone to improve. That's the way I think about it. It affects behavior in addition to kind of being intertwined into the nociceptive system.
Right. Sorry, I was just going to say, I think one of the things that we need to get over as a profession is feeling bad about, we're not great at talking about mental health with patients or psychological conditions with patients. We need to get over that because it's not just us. As a society, we have a problem discussing mental health.
Mental health is health.
But, yeah, right. and other health professionals will tell you that they have the same struggles. So we're not in a unique position on that front by any means. I think we just need to really get ourselves in the habit of discussing mental health with every patient that comes in the room with us. That's what I've done, and I say, look, when I first started practice more than 20 years ago, I didn't talk about this. That it was not something that came up. Your mental health was not something that came up in a...
It was taboo almost, right?
Absolutely. It wasn't. We didn't discuss it in an interaction. But now it's got to be a regular part of the conversation for all of us.
Yeah, and you raised 2 points in your previous answer, that you have time with a patient, and I think our profession has the luxury of time. We don't have to get to the bottom of everything on visit number 1. You do your due diligence, rule out red flags, make the diagnosis as best you can, but it's part of the fact-finding mission to get to know the person in front of you in their entirety. So I think we should leverage that in clinical practice. So what has the literature told us about that in the last few years, and maybe define it for us a little bit?
Well, the therapeutic alliance is basically the relationship between the patient and the clinician, and it's the way that you work together and you problem solve together. There has been some emerging literature that has shown that the therapeutic alliance is something that clinicians and patients both find very important, but it's also got some therapeutic effect. There's benefit to having a good relationship with your healthcare professionals. So it's really important. The way that we develop a therapeutic alliance is a different matter. I mean, one of the first things that I talk about when I talk to clinicians about this is that the first place we need to start at is a place of trust. So you have to, from the first interaction with the patient, you have to be able to build a trusting relationship with people. And one of the first ways that we do that is just in the way that we communicate. So one of the things I've said over time is, the first rule of healthcare is always primum non nocere, do no harm. Right. But the second rule needs to be shut up and listen.
Yeah. Yeah. And I think
really listen.
In the chronic pain space, you see this all the time, and you do longer initial appointments. And I saw this in my practice too, is a lot of chronic pain patients have never been given the opportunity to tell their story. Yeah. And I think sometimes in our profession we're guilty of trying to get to what we're going to do before we sort of let the patient put out what they need or what they're looking for from us. So shut up and listen is good advice. I think there's always that study they mentioned that medical professionals interrupt patients in 18 or 23 seconds or something like that. And I think that's a problem that plagues our profession a little bit too sometimes.
Some of our problem is in the way that we deal with histories. Mm-hmm. We're trained as clinicians so often to, we've got our mnemonic that we work through. It's low Dr. Fakar or something like that. And you have to get all of these answers in, and you've only got X amount of time. So we're rushing patients through their histories. And we really need to just slow down and, get to know them. That matters a lot. In
that teaching model, I always found, and I found this in my teaching career over the years as well, students are so focused on what the next word in low Dr. Fakara is, they're failing to listen to what the patient's actually telling them. Mm-hmm. And that's, I understand why we have to teach it that way, but I feel like there's a way to give them that baseline information. You should get information about all of these factors. However, if you let the patient talk, they're probably going to tell you all that stuff.
Yeah, and I think that's some of the trouble with the biopsychosocial model is people look at it and they're like, oh, this stuff's wishy-washy. It's like, oh, that's common sense. We need to listen to patients. We need to build a relationship. Yeah. But when we look at the studies, we're not as good at it as we think we are. So clinicians are often interrupting patients, not listening, and they might feel like they're listening, but when we talk to patients, they're saying, no, I didn't feel validated. I didn't feel heard. I didn't get to express what I was experiencing, the way that for pain, for example, has impacted my life. So I think there's lots of room for improvement, and I think that's what I'm excited about is moving clinicians in that direction. Yeah.
It's kind of like leveraging existing skill sets, and having clinicians recognize that not only are these things aspects of care that you're kind of good at already, they can actually have a therapeutic benefit for your patients before you even touch them, right? So I think that's important for people to realize.
Listening is therapy is what people often say. It's a therapeutic intervention in its own right. Yeah,
that's right.
And just like touches as well. I mean, we touch our patients by definition, right, with our hands. So imagine, with all the good that we do with our hands, imagine how much more good we could do if, as you said, leverage that additional skill of listening to your patient and understanding what their unique needs are at the time.
Right. And also, as a group, we've discussed the importance of language and the words we choose when we're providing a diagnosis or describing imaging findings and things like that. So What do you guys think the literature tells us about how important that is? Because I think that's a part where our profession needs to upskill a little bit as well.
Yeah, it's just super.
It's a loaded
super
question
important.
for you, Peter.
I think if we're still in the context of like biopsychosocial model, most chiropractors' pain explanations or the way they deliver a diagnosis is largely in the bio realm. So focused on anatomy, focused on biomechanics, and very maybe like an overly narrow approach to explaining a person's pain. So what I'm excited about is like ways that we can maybe better communicate the biopsychosocial nature of pain. So when delivering a diagnosis or a pain explanation, emphasizing that all these different factors, including environmental context, our kind of social factors surrounding us, that can shape the experience of pain. And I think that opens up an opportunity to a variety of other interventions. So beyond just spinal manipulation or hands-on type of therapies, like I think a true kind of biopsychosocial approach is a team-based approach. So circling back to that mental health conversation, working with psychiatrists, working with psychologists, sprinkling in psychologically informed practice as well into a chiropractor's practice, I think is important. So that's what excites me about the biopsychosocial model, is moving towards more contemporary explanations for pain, but also more comprehensive treatment that's targeting all these different biopsychosocial domains.
Yeah, I find that I spend a lot of time in clinical practice trying to change those narratives. So if someone's belief is that they have a degenerated disc, we'll address that. Well, what does that really mean to you, right? What do you believe it means? And then it's just kind of raising their understanding that, you know, just if they do get better, and if they do have times where they do feel better, does that mean the degenerated disc is different somehow?
Yeah.
Like, so you try to make them realize that, oh, okay, part of this really doesn't make sense, and it might explain part of the picture, but not the entire picture. So that listening, therapeutic alliance, that collaboration can really change those narratives and enable people and empower them to be involved in their care. And what I mean by involved in their care, it's anything that they want to do. So if they really value, you know, going for 40-minute walks with their dog every day, or then that sort of becomes the therapy, right? So it's really just about how do we craft a narrative that allows that person to live the life that they want to live.
Yeah, and that part of their therapy could also be an outcome for you as a clinician. Like, can you walk, you know, X number of minutes a day or whatever it is? And, you know, a concept like pain neuroscience education got really, really popular there for a moment. And I think as a group we've talked about how some people kind of went overboard with it in a way, but I still think it has a place in the right context. So how do we fit that in with the literature and what we're seeing in clinical practice these days? Where do we land on pain neuroscience education?
I think it's part of the comprehensive whole, right? So if we think about, if someone has a nerve injury, then you can explain to them that, oh, you know what, there's inflammation around that nerve, there's some scarring around that nerve, and that is associated with XYZ symptoms. But in addition to that, there are all these other variables that might contribute to the experience that you uniquely have. So I've seen people with terrible looking EMG nerve conduction studies, but they have very few symptoms. Or they might have diabetic peripheral neuropathy, but it's not painful. We just happen to find it by happenstance, just out of coincidence. And really, so it's part of a comprehensive whole, right? In that explanation, you have this, but there are all these other variables that contribute to your unique presentation. Now that we understand this, let's unpack the others a little bit. And that just transcends into the treatment plan.
Yeah, and a term you've used, Peter, is neuromania, as it relates to, you know, over biomedicalizing something. And I think in some ways, pain neuroscience education can do that for a patient sometimes, depending on how it's presented. Right?
Yeah, people talk about it in different ways in the literature, so neuromania, neurocentrism. I think we just got so excited about the brain and the nervous system, and I think historically we thought, well, we could just sit a patient down and give them a lecture about the physiology of the pain, and that would improve outcomes. And I think the outcomes weren't as great as we thought they were going to be. And I think if we're thinking about like learning principles, like, I don't know, me personally, I probably wouldn't enjoy if I was living with with persistent pain or I was experiencing acute pain, I probably wouldn't want to sit down and listen to a long lecture, to be honest.
Neuroscience lecture, right? Yeah.
So I get why some people are resistant to that, and what excites me is like potentially more active strategies combined with education. So sprinkling in education with movement, for example, is promising to me.
Yeah.
So, I mean, an example is when a patient comes in with acute low back pain, I might tell them, yeah, there's active inflammation there from X, Y, Z. That's going to lower your threshold. That might be associated with your pain experience. Awesome thing is that will die down over time. The natural course of inflammation is to gradually die down. So why don't we progress you in a way that's in keeping with that?
Yeah, I think it's about finding a balance too. Like I think earlier I talked about like misapplications of the biopsychosocial model, and I think some people will talk about, oh yeah, we're taking a biopsychosocial approach, but be very still narrow in a lot of their explanations. So it's just about the physiology, it's just about inflammation, it's just about the brain. And I think with that, we may actually overlook important social, environmental factors, talk about all the different things that can shape the experience of pain. So sometimes there seems to be a bit of not as a balanced approach, but also there's a lack of integration. So a lack of integration of biological interacting with psychosocial factors. And I think that's, if we're talking about pain, historically been the problem. So people say, well, if we can't find it in the body, it must be in a person's mind.
Pain is all in the brain, right?
So I think we start to run into some conceptual issues there, and we have people like Descartes. He's usually blamed for that type of stuff. We're still holding on to these Cartesian ideas, mind on one side, body on the other.
Yeah, I think in the discussions that we've had in the last few months, it's about applying the right principle or the right tool with the right patient at the right time. And I don't think there's a cookbook here, is there? We've talked about this, and I don't think there is one, as much as clinicians might desire that. And one of the things that this group has done is collaborate on a new e-seminar that we've put together for our colleagues about integrating the biopsychosocial model into chiropractic practice. And part of our production of this course was to shoot a talk like this, and I think this is what this course content was built on. It was us meeting and sort of hashing out these topics and deciding how we can give the best information to our colleagues in terms of how they can apply it to practice. So this e-seminar is now available at ShawnThistle.com. It's called Mastering the Biopsychosocial Approach, a Contemporary Lens for Chiropractors. We hope you enjoy the course, and if you have any questions about this, reach out anytime.